start to move more from the larger policy and macro level toward the organizational, the meso and the micro level of involving patients and family members in quality improvement. And that's what we're going to talk about in this session, as Frank said. Seemed to work. Okay. So my name is Stephen Samus, Vice President Programs with the Canadian Foundation for Healthcare Improvement. We're a federally funded not-for-profit based in Ottawa, and we basically identify proven, evaluated innovations in care and help to spread those across the country. And we do that by bringing health systems together, largely in collaboratives that are trying to adapt and adopt through implementation and good performance measurement, new ways of working in one part of our great country and trying to spread those across the country, and then try to set the stage, as we said earlier today, for scale. And so, for example, actually just finishing, Minister Philpott, the federal minister, Miriam Walsh, who was supposed to be here from the Mount Sinai Health System, actually had to go to a launch today over at Mount Sinai as we're launching the third of our spread collaboratives, which is taking the ACE strategy, the Acute Care for the Elders strategy, from Mount Sinai to 18 teams in different parts of the country. So that's being launched by Minister Philpott today. Basically at CFHI, what we do is we enhance organizational capacity to champion and lead improvement. We are very conscious of the fact that we need to enable patient and family and community engagement in care, design and redesign and co-design. We rely on improvement methods and tools, those developed by ourselves, but also by other organizations in Canada and internationally, like the IHI. And we rely on, as Dr. Tepper mentioned earlier today, some proven ways of working and tools that have worked in other places, and bring them to Canada and incorporate them into the work we do. And also, as I mentioned, we try to bring together these coalitions of the willing, like we're launching today in Toronto, to try to spread new ways of working in care. Great. And Jean-Louis Denis earlier mentioned that we commissioned Dr. Denis and Ross Baker to really look at the evidence and synthesize the evidence. This was back in 2011 on what were the key attributes of high-performing health systems. And out of that synthesis of the evidence, they, and then we, developed this, what we call the 6 levers for accelerating healthcare improvement. And this conceptual framework really does animate much of the work we do, and it animates much of the work that goes on in terms of the collaboratives like the one we're going to talk about today. And as you can see, engaging patients and citizens, and we would say families as well in that, is a key attribute. Forward, please. This is our approach to improvement, which really expresses who we work with, why, in what context, what we're trying to do, and then the outcomes that we're trying to achieve. But the one thing that I highlighted as I click through again, thank you very much, is that, okay, we're going the wrong way. One of those, actually, I think is really key to what we're talking about today. And it's really one of the principles from that synthesis of the evidence. Much of this was built on work we'd already done, for example, for many years through the executive training program, our extra program, but also from the synthesis of the evidence that we commissioned. And that is that large-scale improvement can come through incremental processes. You don't have to boil the ocean. And many of the kinds of things that Dr. Noseworthy talked about that have been going on in Alberta are at exactly that basis, where you start from 1 and you move to 15 and you move to 30 and you incrementally improve across the continuum of care. In terms of patient engagement, we have relied over time on the IAP2 spectrum of public participation. And it's a really good, actually, conceptual way of thinking about participation and engaging the public in participation. It means involving those who are affected by a situation in the decision-making process. And so IAP2 has been a very helpful way for us to conceptually think about how we engage organizations, and we've used it for years through our work in patient engagement and adapted it to that. But more importantly, what we've really been relying on is the Carmen framework, and I have references at the end of this for you for these 2 frameworks. But the Carmen framework really, I think, fits very nicely with the whole point of the conversation today. As you go, as you basically have the various levels of engagement, the micro level of engagement, really at the point of care, the meso level, which is really at the organizational and perhaps regional level, and then at the policymaking. And as Dr. Tepper said earlier, you have to have all of those things working together. You have to have the push and the pull, the bottom up, the top down. Those things have to come together, and that's really when improvement really happens, is when those things do work. At the collaborative we're going to talk about, we were largely up on the top right. What we were really trying to do is move across that continuum of engagement that you see as you move from the left over to the right, and really trying to understand how care could be changed and improved when patients and families are truly at the table co-designing and redesigning care processes. And we're going to hear from an example of that from Mount Sinai, the Mount Sinai Health System, as well as Dr. Patty O'Connor is going to talk about what we learned throughout the collaborative. But the Karman framework really is interesting in that it enables decision-making at each level across the system. It means that you're really thinking and working vertically and horizontally. And it really enables an effective way to bring that patient engagement voice to the table. So what we're going to talk about is the collaborative that we ran in patient and family engagement over about an 16 or 17-month period where we had 22 teams from across the country who were really all trying to build capacity and enhance the organizational culture within their organizations to partner with patients and families at the table. And to talk next about specifically what had been done at the Mount Sinai Health System, one of the 22 teams in the collaborative, we have John Toogood, who is the executive lead in the Office of Integration, Transformation, and Strategy at Sinai Health System at Bridgepoint, and Lily Yang, Director of Quality, Patient Safety, and Risk at the Sinai Health System, Bridgepoint. So over to you both.
Thanks. So we at Sinai Health System are big believers in regionalization. Keep going here. Or really system integration, which is the way at the provider level we tend to think about the benefits. And in fact, I'll describe Sinai Health System a little bit in a few minutes, but just over a year ago, the organization was founded essentially on the belief that we can make big progress on the benefits of system integration. At the level of how we're organized as providers and at the patient level without waiting for the mythical end state of the perfect policy environment. I was mentioning at lunch, I had the questionable privilege of leading policy in the Premier's office back in the mid to late 90s. There are a lot of reforms that we were talking about at the time, bundled care and so on, that we always thought were about 5 years or so away. I sit here today talk about the same reforms about 5 years or so away. We can't wait to get all those things done before we make progress, and we actually have a view that we can do a lot of things now, and we're starting to do that. So mainly, my colleague Lily is going to talk about what we're doing at the coalface with patient engagement, but I'll just make a very quick pitch for what we're doing at the provider level. At a CFHI discussion, you may not be surprised to hear that we agree with CFHI about the value of regionalization and about where we stand on it now. In particular, we have a strong belief that there's a lot we can do to reduce unnecessary variation in care, and that's particularly true for these complex multimorbidity patients who are the disproportionate focus at Sinai Health System. And that's in part because these patients are so different from each other. There's not just a single checklist like you might have for removing an appendix. You need mass customization for these patients. People with 5 morbidities are not all the same as each other. But at the same time, because nobody knows what works for a patient who's on 12 different medications, which is the norm in many of our programs, not the exceptions, we need big data, we need new evidence, we need the heft of large academic institutions leaning in and sharing what actually works for these patients to reduce that variation in care. We also believe that it's possible to have good acute care, good primary care, good home care, good rehabilitative care, and yet have mediocre or lousy care overall, because our evidence tells us that where these patients inevitably have the bad kinks in their trajectory, where they inevitably have bad outcomes, is when they go through transitions in care and when they have gaps in care. Now, lots of things we can do about that. One of the things that we're doing is actually vertically integrating our little bit of the system. And we can talk about it in the Q&A later if you're interested, but we find when we put the acute organization and the home care organization and family health care and rehab and so on together in the same organization, when we bundle the providers, it aligns the incentives in a big hurry, gives people a new perspective on what the overall trajectory and pathway of care looks like. It's not a perfect answer, but it helps us make big progress, and we're big believers in it, whether it's done through mergers or through different kinds of partnerships. What we've put together, I said I'd describe Sinai Health System a bit, is Mount Sinai Hospital, of course, on the acute side. Lily comes to us from Bridgepoint, which is a complex continuing care and rehab hospital. We also have in the family a large home care organization, Circle of Care. We have a research institute, not on the slide, but we have 3 family health teams, a number of community programs, like the biggest palliative care community-based program in the GTA, and it's that breadth that we think actually allows us to make progress even before we have comprehensive changes in policy. Now I'm going to shortchange this next slide, which we could talk about for 10 minutes alone, by giving you just kind of one core concept of what we think we need to do for these very complex multimorbidity patients. We think the answer for these patients is in large part a medical home that requires more capability than primary care alone is ever going to be able to deliver. So you see that medical home requiring the capabilities of primary care, ideally family health teams and so on, but in partnership with a large, capable organization like Sinai Health System that can provide the access to specialists, the diagnostics, the day hospital, the system navigation, the big data and evidence that no family health team alone is going to be able to provide. And when we invest and put those services around the patient, we can break what's on the left side of the slide, which is this cycle where they go in and out of acute care, back to the community, and then to places like Bridgepoint, where we very politely call them post-acute care, showing our acute-centric view of the world. You never used to be able to get into Bridgepoint without an acute admission first. That's one of the big things that we're trying to change right now in order to build this circle of care around the patient. So a very quick view of what we're trying to do at the provider level, Sinai Health System. I'll let Lily talk now about what we're actually doing with patients.
Thank you for everyone for having us here today. I'm here to talk about one project in particular, and that was around the redesigning of our admission process in our orthopedic unit. And I'd like to start that by thanking CFHI for the very generous support they provided us over the year around coaching and mentoring and skill building for all of our teams around this process. And you're going to get to see some of the outcomes of that work. Very quickly, as John mentioned, Bridgepoint is an organization that's focused within Sinai Health System on rehab and complex continuing care. We have 414 inpatient beds. We have an ambulatory care and palliative program in addition to rehab and CCC. Where we focused our efforts was on our orthopedic unit. And the reason we focused there is because we have 700 admissions into that program every year. 50% of those admissions are same-day admits, which mean the same patients that are coming in are the same day of the patients that are leaving. And we have about a 96% occupancy, which doesn't leave us with a lot of room on that unit for things to slow down too much. So what we were trying to do very broadly at the start of that project was to improve the experience of patients and families during transitions in care. And looking at our quality improvement plan as an organization, broadly, we were saying, okay, we want to make some shift happen in continuity and transitions in patient satisfaction, and we started at a baseline of 72%, where we saw that our peers were actually at 83%, so we had some space there. And then in terms of length of stay, we were at 28 days for that orthopedic program, and our peers were at 21 days. So perfect place. It's a busy unit. This is obviously a center of some attention that's needed. And so we said, okay, how are we going to do this? We looked at getting this aim into a slightly more narrow focus, and we started looking at achieving exceptional patient and family experience with the admission process in the first 48 hours on our orthopedic unit by December 2015. So relatively smart, except for the part where we're not really sure on the what exceptional patient experience meant. We knew when we thought about how are we going to do this, we're going to use a methodology that we have been learning a little bit more about at the Bridgepoint site around experience-based co-design that comes from the UK and the NHS. And we knew we had a set of quality improvement tools in our back pocket, and we knew that we actually needed to be working with patients and families in order to actually be successful around this. And so that space in between there around co-design is where we were trying to focus our efforts. So the first tool we had was this tool where we were trying to capture and understand the experience of our patients and families. So what's on the bar, above the bar are all the very positive emotions around being happy and content and safe in the experience of our patients. And below the blue bar are all sort of the negative experiences of being in pain and frustrated with their care. What you see on the bottom on that x-axis is sort of the touch points that we saw. And so that's around pre-admission, within sort of that admission phase, the first 8 hours, the first 24 hours, and then within that first 2 days. And of course, I can't see anything in that screen over there. So I'm going to go with approximately 60-something-ish% of our patients were positive in that first 2 blocks. And the remainder of those patients were feeling quite negative about their experience. And so when we give you some of their quotes, and again, I have no idea what that says this second because I can't see it, essentially it's telling you that the patients didn't know what to expect on arrival. And that's not really surprising because when we looked at our own website, what we found is we have this beautiful building and patients were looking on this website because a lot of orthopedic patients are already elective surgery as well, and they know they're coming, so they look up our website, and of course there's no picture of any rooms, and on that website all it sort of tells you to do is not to bring in electric kettles of your own. It doesn't actually give you any information about what you should expect. And you can see that again, another family member looks up our website and isn't able to find anything. We did get some positive comments. We interviewed 15 patients to try to capture their experience, and this was on day 3 or 4 of their arrival. And so good news is we had a good view of out of that room. They didn't know what was happening, but that was what was happening for them. And then another experience was really around a patient with spinal stenosis who found themselves on a stretcher in our hallway for several hours and certainly in pain. And we had another patient who was drowsy and dizzy in our hallway and also uncomfortable. So we have then a few good experiences with nurses and team members telling our families who they are and settling them in. And then right at about the 48-hour mark, what happens is as the assessments get completed, patients started to realize what some of their limitations were, and then they started to express some realization that they had fears of falling and other things like that. So where we decided to focus our efforts, though, because we can't boil the whole ocean, was just in that first 2 buckets around pre-admission and the unit admission itself. We concurrently had mapped out the process with our staff, and we found very similar statements from our staff that said they were most frustrated at the beginning at admission because they had patients in hallways. They said patients weren't leaving by 10 o'clock, which was our discharge time, and by the way, your patients are arriving at 8 o'clock, 9 o'clock in the morning from acute care, so everybody's kind of in a bit of a bottleneck. So then we actually got to our co-design event, and we invited a number of people, including 1 patient, 2 family members, physicians, our staff, our nursing group, our administrators and leaders, and they came together on that day to think about redesigning 2 pieces of our work. And that was, first of all, knowing what to expect on arrival, and then that whole hallway wait business. What turned us around, so they generated a number of change ideas that I won't go through the whole list, but one of the things that turned our head completely around was when the patient actually said to us, can we shift the burden of waiting instead of the patient that is coming, who is in pain, disoriented, doesn't know what to expect, who's lying in your hallway stretcher, to the patient who's already being discharged? So those are the people who already are they've had a rehab stay, they know where the patients, or they know what's going on, they know who to approach, they know the nurses, and most importantly, they know where your Tim Hortons is. So the question was, could we shift that burden around? So very quickly, our admission process redesign turned into our discharge project. And that was through patients and families. I see something hasn't shown up there. But what was created then was two key change ideas I want to share with you. The first one is we created a video around knowing what to expect. And so when you went onto our website, one of the things that you will see on that video, if you go onto that link, is essentially, and you don't need to go to the link because it'll take too much time right this second because I can see them back there. What will happen on that video is you start to see who are the staff. You see the orthopedic unit, you see the rooms, you see the equipment that will be used, you see the gyms. The other thing that's on that website now there's a brochure that actually tells you what to bring. So bring your hearing aid, bring your tablet, bring comfortable running shoes, things like that, so that patients have a sense of what's going to happen in rehab. We also had an open house where we brought our acute care partners in so that they could also be ambassadors to tell patients and families what to expect when they came to our program. The second big piece of work was around discharge tools. One piece was this checklist, and it turns out that patients, when they arrived, or when they were leaving, had large difficulty actually getting out the door because of simple things like not getting their things packed together, not getting their rides organized. So this checklist counts you down from 5 days, 4 days, 3 days, 2 days, and 1, so that you get to the point of being very ready to leave the organization. So in terms of the actual change ideas and how we did, I said to you we had about 700 visits to the orthopedic program, and so on the video itself we had 761 hits to that video as of last year. And overall we now have 0 patients waiting in the hallway. We have, this is a little misleading, we have 18% of patients leaving between 8:30 and 9 a.m., but the good news is actually there's many patients that are leaving before that time. And so some of them, once they're all packed up and we've got volunteers helping to pack them up now, they're leaving the night before. And so our length of stay has actually dropped as a result of, they're thinking, why am I all packed up and ready to go and why am I staying and sleeping here tonight? So they go. So that's actually all very positive news. In terms of those overall outcomes, what did we see? Well, we administered interviews in November for 10 patients just to capture their experience again. And you can see that those 2 points where we were at 67 and 62% have increased overall to positive comments of 87 and 100%. So people aren't in the hallways and they're feeling a lot more comfortable. But the PICR, that patient satisfaction, continuity, and transition survey, has gone from 72% to 88% on that particular unit, which is incredible. It speaks a lot to that discharge piece because, of course, those survey questions are about those discharge questions, so that was actually quite remarkable. And then the hip fracture length of stay through numerous projects, but this is definitely one, dropped from 28 days to 21.6 days as of Q3 this year. In terms of organization-wide, I just want to highlight to you that it isn't just one project that's going to make a change in that big dot for that organization. And so you can see this is Bridgepoint overall, and we committed to a quality aim in 2012 of making improvements in continuity and transitions, and we started at 67%. You can see we're just approaching that 80% mark, and it's fairly significant due to any number of initiatives, of which this was one. Successes, challenges, and opportunities. Overall, our successes have been really around good adoption of that methodology of patient experience co-design, patient experience-based co-design, our working with our staff and our patients and our physicians. Challenges have been around that staff anxiety around what to expect when they work with patients, and so and families. So the typical question of, are they going to expect the moon? Are they going to expect us to open 10 more beds, do something that we can't possibly do? And of course, none of that came true. And in fact, it was a hugely beneficial partnership. And then those opportunities, we've already spread this to the other orthopedic units, so the change ideas were quite applicable in that area. We've looked at standardizing our discharge tools. We have adopted that experience-based co-design methodology across the Sinai Health System for our next QIP in 16-17 that looks at using this methodology on 80% of our corporate quality initiatives. And so those are some of the simple challenges and successes. But I'm going to leave the final word to our patient who couldn't be here today, but she has given us a little thought.
I have a lovely little 5-year-old daughter at home, and for the past 10 years or so I've worked in the hospitality industry, in the hotel and housekeeping. Well, working with the team was great because everybody kind of had their own input and everybody was open to hearing everybody's piece of advice. So where they felt there were areas of improvement. You guys were very open to hearing, what our input to redesigning the care would be like. For a lot of our clients would say, okay, we need a late departure, or we need an extra day. So you know ahead of time how many rooms you're going to have, when you can clean them, when they'd be ready for other people to get into. So letting you guys kind of in on that little secret, knowing when people are supposed to be coming, gives you that time frame of when you can get the room ready. So allowing the patients who have been here already, they've kind of had their rehabilitation time, and they know the hospital, maybe place them somewhere that, whether it be a special room that have been locked off with some comfortable chairs that they can stay in, or even going in and having Tim Hortons that way, so you have the time available to get the room ready for the person coming in so they don't have to wait in the hallway. Honestly, I think it's one of the most fabulous ideas that anyone has come up with, because really and truly, you guys are here to help us get better and get on our feet and get out there and start, being part of the community again. So working together is one of the real big things.
Thanks, John and Lily, both. It's a really excellent example of the power of working with patients and families, and what happens when you bring the patient voice to the table, and you really begin to see the care process through the patient and family eyes. And you really, some things that are not rocket science, they're actually quite simple things, make a huge difference to patients and families. So kudos to Mount Sinai, not only on the organizational transformation that you've been on, which is quite extraordinary, but also for working directly with the patients and family members on the co-design project. And Crystal's virtual presence here really reminds us what this whole meeting is actually all about. So thank you so much. I'd like to finally introduce Patricia O'Connor, who's Senior Advisor of Patient Engagement at the McGill University Health Center. She's also a Clinical Improvement Advisor to CFHI, and in fact was the lead faculty of this whole collaborative. And what she's going to be sharing with us now really is some of the summary. We're doing a lot of evaluation of all the collaboratives we ran over the last while, and really a summary of some of the work that we've been doing through the surveys and the interviews with the teams to try to distill for us in broader terms what this collaborative has actually generated. So, Patty.
Thanks, Stephen. So just to remind you, the aim of this collaborative was to improve quality of care across the healthcare continuum by building capacity and enhancing organizational culture for partnering with patients. We had 22 teams from 6 provinces and 1 territory. We had a little team from a pediatric rehab center in Whitehorse, Yukon. The collaborative ran from July 2014 and just ended at Christmas of 2015. And the foundation provided up to $50,000 of funding support for each organization. We hosted 11 webinars and 1 in-person workshop over the 17 months, and each of the teams was also provided with 1 to 2 coaches who had expertise in quality improvement or in partnering with patients. The participating organizations represented diverse healthcare environments across the continuum of care. 7 were from primary care and community care, including 2 dialysis centers. 4 were rehabilitation or continuing care, 9 acute care, 7 of which were adult, 2 pediatrics. And we had 2 organizations that were a mix of acute care and cancer agencies. The top 4 domains of quality that they chose to focus on, everybody really was focusing on patient experience of care. About a quarter were focused on coordination of care or transitions, half the teams on effectiveness and appropriateness, and another quarter on patient safety. And not surprisingly, most of the teams were in fact looking at multiple quality domains. This collaborative involved quite a few first-time experiences for the participants from the 22 teams. For most of them, this was their first time that they were having patient advisors directly embedded on a quality improvement team at the front lines. So time was spent in webinars addressing how to recruit and orient advisors, as well as reviewing the main elements of patient and family-centered care. Several teams targeted improvements in staff communication to improve patient and family experience of care and patient safety. Some examples include learning how to effectively use teach-back methods for discharge preparation, learning how to conduct end-of-shift bedside report with patient and family participation, and with primary care teams, trainings with the staff focused on how to better support patients in their self-care management journey with chronic illnesses. In many cases, it was the first time that frontline staff themselves were being trained in quality improvement methods such as lean process mapping and Kaizen events. Multiple webinars provided by the Foundation focused on how to develop a comprehensive evaluation plan, including the choice of process and outcome indicators, setting performance targets, and learning how to conduct frequent tests of change. So again, I think back to some of the comments from earlier this morning. What we were really doing was working the reform at the clinical level here. And it was really teaching frontline staff, most of whom did not know how to do those things, about choosing the performance indicators and setting those targets and monitoring that, using real-time data, most of which they were generating themselves. And experience-based co-design methods were also included in the curriculum, as you heard illustrated well in the Bridgepoint example. So mutual learning with patient advisors and staff together learning was an integral part of the program. You've heard Bridgepoint's story, and now I'm going to describe briefly a few other cases that illustrate improvements in other quality domains. Vancouver Coastal Health and Fraser Health Authority, so two different regional health authorities, joined forces to launch a new program called Good to Go, partnering with patients and families to improve patient experience for a smooth and safe transition home after hip fracture. Their baseline data that patients and families felt confused and distressed when returning home. They felt ill-prepared to handle what they had to face. And keep in mind that 22% of hip fracture patients go through readmissions, and at least a quarter of those are preventable. Their project's aim was to see a 10% improvement in patient self-reported experience of their transition home from hospital to community. And they were doing this by improving education, early mobility recovery, and community support, addressing self-management and systems gaps at 3 different acute care sites. And they were also using this opportunity to link with another initiative that had been developed in BC, and that was what they had developed, the Fresh Start Toolkit, Fracture Recovery for Seniors at Home, and they used that as their framework for self-management. So this slide is a run chart that shows progress in percentage of patients reporting positive experience of care over time. As we all know, it's not a straight line. It's up and down. The horizontal axis is showing the number of weeks. Where you see the first red arrow at 22 weeks indicates when community in-home support services were introduced, and that took a partnership between the acute care teams and the community-based teams, and again, cutting across 2 different health regions. At week 37, where you saw a major kick-up in terms of improvement in scores, the pharmacist bedside coaching and follow-up calls were introduced, a really important and innovative intervention. And here you see their overall results were a 20% increase in patient experience following discharge. The graph on the right just shows a little bit more detailed breakdown of pre and post results on specific aspects of preparing them for transitioning. Coordination of care at transition points, including admission, discharge, and transfer, was the quality improvement focus at Bruyere Continuing Care in Ottawa. New for this team and organization was using experience-based co-design methods such as storytelling by patients and families to illustrate and captured on video. Hearing these powerful and enlightening stories, just like we heard from Crystal, provided staff with new insights and an appreciation for the patient and family experience. And by introducing lean methods with frontline staff, they were able to eliminate waste and duplication while developing more responsive work processes for admission and discharge. At Bruyere, transforming the patient care experience at transitions led to the rollout of what they refer to as always practices. Always practices are aspects of patient experience that are so important to patients and families that providers must perform them consistently every day with every patient, every time. They heard from their advisory committee that patients and families wanted to be more included in the plan of care, and so they began conducting bedside handovers using patient co-designed care boards. Patients indicated that they wanted to see their nurses more, and so they introduced hourly rounding. And the clinical teams told leaders they wanted better the clinical teams, in this case not the patients, told their leaders they wanted better communication, and so priority huddles and lists became part of the intervention bundle. And I just want to also mention that we just heard news today that Briere has just received recognition by Accreditation Canada for 2 leading practices from this initiative. The Briere case study illustrates well the ripple effect that occurs when you take a deeper dive in really listening to what patients and families have to say about their care experience. In addition to launching the Always program, they developed a new volunteer ambassador program, established a patient and family advisory council, and partnered with CCAC and the Champlain Lynn to open the Path to Home Resource Lounge. And it's the volunteer ambassador program and the Always practices that just received the Accreditation Canada recognition. At Stollery Children's, family bedside orientations were the initiative they launched during the collaborative. This program involved the introduction of a new role, volunteer peer mentors, who are parents who have personally experienced caring for a child in hospital. To strengthen a culture of patient and family-centered care, this organization targeted 3 specific areas for improvement: embedding the peer support initiative on the unit, improving patient safety by changing both staff and family practices and communication with regard to hand hygiene, medication reconciliation, and education. And the third intervention was supporting family engagement with their child's care by encouraging participation in bedside medical rounds and the use of whiteboards at the bedside. This next slide highlights the key topics or types of support that were provided during peer mentor and parent-caregiver conversations. These include encouraging families to discuss their hospital journey, providing information about how to navigate the healthcare system, discussing ways parents can advocate for their child's care. Thank you. And supporting parents as their child transitioned to another level of care or was discharged home. And here you see information about the recommended timing of different support interventions based on feedback from the peer mentors. So again, remember, these are volunteers, these are parents, and they've actually become a new member of the healthcare team and not only observed what's needed, but have then put together basically a roadmap on the timing of those different interventions. Because what's most often needed within the first 24 hours versus on days 2 and 3 when a family's still anxious about what's going on in terms of the diagnosis and treatment, versus a scenario where a child's hospitalized for a month and where clearly at that point there are enormous impacts for the whole family. The teams in the collaborative learned ways of tracking changes to see if there was an improvement or not. And they were encouraged to conduct frequent measurements following PDSAs and to post the results in public spaces, not back in med rooms or in back offices, but to get them right out there in public view so that both teams and families could see that these patient engagement activities were a priority. This slide shows progress related to 2 key performance indicators, the whiteboard use and participation in medical rounds at the bedside. And again, I think the most important thing that it illustrates for me is that it's quite different when frontline develop their own indicators and monitor it themselves, and they can do it in real time. The kinds of indicators that are of importance to the corporate office are usually not of much interest. I'm being very honest. I worked as a director of nursing, as a nurse executive for 15 years. They're not of the same kind of relevance and interest, and frankly, they're all usually quite late. The earliest you get them is a quarter later, so 3 months old. Here, we taught them how to identify the problem, the solutions, and then do simple pre- and post measurements. That's what made a difference for them. So right now, we're in the final phase of evaluation of the collaborative, conducting interviews with the patient advisors from the 22 organizations, as well as conducting a limited number of team interviews. The aims of the conversation with our patient advisors were twofold: to understand their lived experience as a patient advisor on these 22 teams, and to ask their advice about how to strengthen patient partnerships in the future. The advice they provided includes things like, involve me from the beginning of the initiative, not after you've defined the problem and the set of solutions. Get me there at the beginning. Make sure the rest of the team, and especially frontline staff in the area, know why we are here. Usually that was well done, but not always. Facilitation by the team lead was very important in setting the stage for receptivity and listening from both staff and advisors, as were the messages from the CEO and executive leaders that this is an organizational priority. Advisors have a keen sense about who is on board and who isn't. Invite more than one patient advisor. It allows for better balance, and it makes it easier to ensure patient advisor input when one is sick and can't be there. They also said, let us do more than just tell our stories. We have our own history, we have our own expertise, either with our lived experience in our illness or just from our own careers. So they played many, many roles, in fact, and it's really neat because we're now hearing from them what that range was. They were involved in training staff, so this is beyond just the storytelling, and actually doing the training with staff, in setting up role play scenarios, collecting feedback from admitted patients about the changes that had been introduced, because they said, we get a different story than you do when we go to the bedside. Reporting the results to the board, quality committees, and within the community. Make sure out-of-pocket expenses are covered. And lastly, they've talked about the importance of recognition, just simple ways in which senior administration acknowledged the time and commitment. And Sunnybrook was a lovely illustration. They just had a dinner recently for their patient advisors and members of their patient advisory councils. So in closing, what were the critical success factors and lessons learned? Patient advisors need to be treated not as guests, but as partners who bring their own expertise to the table. Early and continuous stakeholder engagement was essential not only at the beginning, but particularly at the end of the pilot testing, when sustainability and spread plans required different levels of organizational commitment. In any change initiative, senior leadership support is critical. We know that. Creation of mutual learning environments for patient advisors, staff, and physicians was another success factor. Measurement, again, emphasizing at the unit and local level the collection of real-time data so they could see concrete results and change over time. Communication of the ongoing progress to the board, senior management, was a key element in maintaining visibility and ongoing support. And last, teams identified the coaching support provided by CFHI as being very much appreciated by them. One final outcome of the collaborative was the creation of an extensive patient engagement resource hub. There's an incredible wealth of information about resources that can help organizations in their patient partnership journey. So this is really about not reinventing wheels. The resources are there. I encourage you to check it out on the website. It's on CFHI. And since October 2015, it's available as an app. Thank you very much.